Dear audience, thank you for having me here, and sorry for extending your afternoon a little. My PhD topic is procalcitonin guidance for optimal antibiotic therapy in critically ill patients. I'm an anesthetist, a clinician in St. John's Hospital and a PhD student, and my vision is that inappropriate antibiotic use will be a bad practice from the past one day, and my mission is to protocolize and individualize procalcitonin use in everyday practice in the intensive care unit. Here you can see my specific goals. My first is to investigate the effects of procalcitonin-guided antibiotic therapy versus standard treatment in critically ill patients with the methodology of systematic review and meta-analysis. We know that inappropriate use of antibiotics has serious adverse effects like emerging antibiotic resistance, which according to WHO caused around 700,000 deaths in 2014. But on the other hand, the current guideline tells us to give antibiotics early, ideally within 1 hour of recognition of a septic patient. And we know from previous trials that we can reduce the length of the treatment with the use of procalcitonin with a median of 2 days, but we still don't know, it is still unclear when to start and stop the treatment and whether using PCT can help this. So our aim was to investigate the efficacy and safety of this PCT-guided management versus standard therapy. So the question was that this procalcitonin-guided antibiotic therapy reduces the length of antibiotic treatment without causing harm to our patients. Our patients are adult patients treated on the intensive care unit. The intervention is PCT-guided antibiotic therapy, which means there is a predefined PCT protocol for starting and or stopping the treatment, which can be overruled by the physician. Standard of care is the comparator, and the outcomes are length of the treatment, mortality, recurrent and secondary infection, and length of stay. And we hypothesize that using PCT-guided antibiotic therapy reduces the antibiotic use without compromising patient outcomes. And with decreasing antibiotic use, we can decrease the antibiotic-related adverse events and even healthcare cost. And after the selection, we had 26 articles for the quantitative analysis. Our primary outcome was the length of antibiotic therapy in days. The outcome measure is mean difference. And you can see the risk of bias assessment and the grade assessment depicted on the plots. And here you can see that in the PCT-guided group, there is a 2-day decreased antibiotic therapy, which is clinically relevant and statistically significant difference. Our safety outcome was 28-day mortality. The outcome measures odds ratio, and you can see that it is 0.84, which means that in the PCT-guided group there was a 16% lower 28-day mortality, which is clinically highly relevant and even statistically significant result. And because the sepsis definition has changed, the previous one was a bit too specific with this infection plus systemic inflammatory response syndrome. As previous was told, that the new sepsis 3 says that sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to an infection, and the emphasis is on organ dysfunction because there is a minimum change in the so-called SOFA score with 2 points, which reflects an overall 10% mortality in a general hospital population with infection. So the sepsis 3 criteria defines a more homogeneous and a sicker patient population. So therefore we made the subgroup analysis in sepsis subgroups, and here you can see that in the sepsis 3 cohort, the length of treatment was even more reduced. However, these 3 days is not a statistically significant difference. But if we looked for the 28-day mortality, the same subgroup analysis, you can see a very big difference. The mortality is more than halved in this cohort. One of our other safety outcomes was a recurrent infection, which means that the same pathogen causes an infection at the same location as the primary one. And here you can see the outcome measures odds ratio that in the PCT-guided group there was a significantly higher odds for the infection of recurrence, 1.4 times higher. However, if we look for the details, the overall event rate was low, below 5%. So as a summary, we can say that we used only RCTs. This is the most comprehensive meta-analysis in the field at the moment. And we are the first to analyze sepsis through groups, but of course we have several limitations. First one is the high heterogeneity regarding infection type and severity, the different PCT protocols used in the studies and the standard of care even, the protocol adherence, the lack of reporting on antibiotic appropriateness, and the exclusion of immunocompromised patients. But at the end, as a conclusion, we can say that we can reduce antibiotic use with the use of PCT guidance, especially in those regions where the routine antibiotic administration is more than 7 days. And PCT guidance may be accompanied by higher rate of infection recurrence, but despite of that, it may be associated with lower 28-day mortality. And the major clinical implication is that we should individualize antibiotic therapy as well. And procalcitonin does have an important role in that. And if we look for the guideline, maybe we can say that procalcitonin deserves a higher support in this issue, because the actual guideline contains a weak recommendation with low quality of evidence. But we have several implications for research, as the actual guideline, the same guideline, contains a weak recommendation against using PCT in the decision-making of starting the therapy with the clinical evaluation. And we think that new RCTs are needed in this field, and even new RCTs are needed for using different protocols in medical and surgical patients and investigating these elevated odds of infection recurrence. And at the end, we were very happy that we published our paper in Critical Care, and maybe outlining or highlighting the importance of the topic, not our results, but the topic, because I think it's an under-recognized problem, this high antibiotic resistance and antibiotic overuse. We had to participate in some sepsis update conference and was awarded in the poster sections, and we have just arrived from Ostrava, the corrosive sepsis conference. And as I mentioned, we need new RCTs for starting antibiotics and the PCT issue in this problem. So our second project is a protocol of a multi-center randomized trial investigating using PCT kinetics to guide antibiotic therapy of critically ill patients with suspected new onset infection. Just a little about the background. We know that every second ICU patient considered as infected, and the infection can more than double ICU mortality. But on the other hand, up to 40% of our ICU patients get unnecessary antibiotics because they do not have bacterial infection. We know that procalcitonin is the well-known, best-known sepsis biomarker, and we can use the absolute values or the kinetics of PCT, but we don't know which one predicts better the bacterial infection. Therefore, our aim is to investigate if antibiotic initiation using the kinetics of PCT can decrease unnecessary antibiotic use compared to using absolute PCT values or no PCT at all. So our patients are adult ICU patients with a new onset infection, and we plan a 3-arm trial with intervention 1 using PCT kinetics, intervention 2 using absolute PCT values, and the comparator is antibiotic initiation without the procalcitonin use. And our primary outcome is rate of unnecessary antibiotic therapy. Secondary outcomes are mainly organ support, 3 days, length of stay, mortality, number of multi-drug resistant organism-caused infections, C. diff infections, and kidney injury. And we hypothesize if we're using the kinetics of PCT, we can reduce unnecessary antibiotic treatment compared to using absolute PCT values or no PCT at all. And the clinical implication is the same. We would include adult patients with new onset infection admission or during ICU stay when we highly suspect or know the source of infection, and there are 2 PCT values available, and every microbiology sampling has been done according to all presumed sources. And we would exclude if long antibiotic treatment is needed, like an infective endocarditis, when the adequate source control cannot be guaranteed after cardiopulmonary resuscitation or poor chance of survival, and patients on antibiotics before patients with immunocompression, suppression, and non-pregnancy. and now we are preparing the protocol. So at the end, my quote, he who fights can lose, he who doesn't fight is already lost. Thank you for your attention.
First of all, congratulations. It's a very nice topic with a wonderful presentation. And my question would be, you said in the included studies in the first project there was the heterogeneity regarding the diseases that the patients had. But based on the literature, did you find any evidence that this procalcitonin-guided therapy is better in some infections compared to other infections?
It's a very good question. The strongest evidence is for lower respiratory tract infection. There is a big individual patient data meta-analysis in the topic investigating this, because we know more and more that there is no such syndrome or no such patient, septic patient, because sepsis is a very heterogeneous syndrome. And we should make a subgroup analysis, or the plan is to make a big individual patient data meta-analysis and look for the different types of infections. But this is the one which we have the strongest evidence for.
I would like to ask that do you have any idea that maybe there would be any additional factor like procalcitonin that can be added to optimize the end of the antibiotic treatment? Because as far as I see at the start, this is fantastic, but because of the higher infection recurrence rate, maybe there will be some space to have any additional factor.
Yeah, for stopping, maybe there are a lot of experiments investigating prognostic factors and diagnostic factors, but there is no such thing, I think, it's my opinion, that you can use to diagnose. You can look for the kinetics. There are other biomarkers which are not used in everyday clinical practice, like presepsin, but for stopping the therapy, I don't know any. Of course, we speak here in a sepsis puzzle, so you look for the PCT, you look CRP, you look leukocyte number, and you look the patient, and this whole picture gives you an idea. Should I give antibiotics or should I stop?
Can this be implicated to other clinical disciplines or to the everyday practice as well, not only in the ICU? I'm meaning like
absolutely
other infections.
There are a lot of trials. We have a review part of. I didn't speak about that, but for example, in America, in the USA, they use it for primary care. So there are some studies where the general practitioner have a point-of-care PCT machine, and she can use it, and you can use it in the wards, in the ER. The most important part is the ER, because the patient comes to the ER, and if the patient is unstable and you think that maybe he or she has an infection and sepsis, and this is the cause of the instability, you should measure a PCT, because it is part of the picture.